Yeah, well, yeah, and thank you, and you know very well that I would prefer to be there in person, and prefer to have the opportunity to engage with my friends and colleagues, and I mean it's just always such a great course, and I always learn so much, and I'm sorry I couldn't be there. Um, I'm going to talk about a couple of things. So the reality is that when you get out and practice, it doesn't matter where you practice, you're going to serve as a community resource. And you're going to get questions like this time and time again as people come to you, whether they are adult weekend warriors or they are the high school athlete, or they are the person for whom athletics is a professional enterprise. You're gonna come across the challenges of facing spinal disorders in this population, and then there are always some nuances associated with that may not necessarily apply to the 45-year-old accountant who's just trying to get back to work. So we'll go through a few of these in a case-based format. These are my disclosures. All right, it's a 21-year-old college football player with transient burning hands. And, this is a very, very important thing that there can be the confusion between what a stinger is and what is something more significant than that. And so I hope everyone understands in that room that that bilateral symptomatology is by definition not a stinger, and you cannot be managed accordingly. And I was just sent an athlete recently with this very thing, that in the initial management was in the context of a stinger when the symptoms were bilateral. So by definition, bilaterality is not a stinger. So this person had transient burning hands bilaterally. That should prompt a more detailed investigation. And this particular player was being taken care of by athletic trainers who understand that that is something different and requires further investigation. And so here we go. Which resident in the room there wants to volunteer to work through this case with me?
Looking for volunteers. Determining a volunteer. Here, Dr. Newman. You look like a sporty type. Harborview. Tell us what to do.
Sure. So, interpreting these plain films and MRI imaging from a bony alignment, young guy, preserved cervical lordosis. Looking at his MRI, it looks like he has a disc bulge, disc herniation it appears to be C3, C4. Also, just looking at his plain CT, he may have an element of congenital stenosis as well.
Yeah. Yeah. And what is that measurement that you're thinking about when it comes to congenital spinal stenosis? Do you know?
Absolute number or ratio or?
Yeah. So the ratio is a great way of thinking about it. But if we talk about absolute numbers.
I believe it's somewhere around 10.
Yeah. So the key there is congenital spinal stenosis is really, if you're less than 12 millimeters, it's the 10 millimeter number is where you get into the place where a lot of people view that as an absolute contraindication to a contact sport. So that's where the 10 millimeter number impacts that conversation. 12 millimeters would be a good cutoff in general for congenital spinal stenosis. Yeah, and interestingly, in the contact sport athlete population, particularly in football, C3-4 is the most common level affected, which is different from what you see in the general population, where it tends to be C5-6, C4-5, then C6-7. But C3-4 is the most common level in the football player population. All right, what do you want to do with this gentleman?
Dr. Newman, do you want to pass off to your partner at Harborview and tell us your name?
I'm Varun Sambaria, another Harborview Spine Fellow. So obviously, this guy has the 3-4 disc herniation, as we discussed, and potentially some congenital spine stenosis. So would potentially want to do something motion preserving for this patient, potentially a laminoplasty or something of that nature.
Wow.
Laminoplasty. There's a resident back here, blue and white shirt. What's your name? What do you want to do with this patient? What do you think about laminoplasty, resident?
Dave, welcome. Glad you could show up.
Hello, my friend.
Here, but that's all right. What do I think of laminoplasty? I think laminoplasty is a great operation. Here, I mean, first of all, we define the guy needs an operation. Do we have a neurologic exam? Do you guys do those in Pittsburgh?
No, we don't. No, we just send everybody to Philadelphia and just send them to the experts in Philadelphia. This gentleman has had resolution of his burning hands. Okay. But he's had this episode, and he's a college football player with NFL aspirations. And I don't know how well this projects, but there is T2 signal change in the cord behind that disc at C3-4.
No, and I guess I'm just sort of going back. I mean, to me, the big thing is when you see these people is their neurologic exam. If this kid came into me, he was 100% neurologically intact, I'd probably ride him out and watch him. If he wants to go back to college football, I think that's a different answer. And I don't think laminoplasty is going to get you to NFL. And looking at the muscle on this guy's bone, I don't know what position he's playing in the NFL, but it's probably not going to happen.
Oh, that's cruel. All right. Well,
since there's already cord signal visualized, is there any reason to get Flex X MRI?
Yeah, I have done that on a limited number of occasions. In this situation, I did not do that in this situation. So I think Varun was his name. I think Varun brings up Varun's indicated or suggested surgical approach of a laminoplasty goes right to the heart of the topic of this discussion, which is approaching this differently in the athlete and understanding also the sport that athlete plays, because the answers are different for a tennis player than they are for a rugby player. And so when in the setting of someone playing a contact sport where you have high impact, high frequency, as you do in football and rugby, a laminoplasty creates some challenges for getting this person back to the sport that they intend to play. And then we can also have that conversation about, does it make a difference if this person, is a high school player who's on the JV squad, in which case I think Dr. Harrop's perspective of doing nothing is actually most likely the correct answer. And then you can talk to that person about whether they really have a future in that sport and whether they should ever return to that sport versus the person who is at a major college football program with NFL aspirations. And so in this setting, with a 12 millimeter canal diameter, a C3-4 disc herniation, T2 signal change, and this history of transient burning hands, which, as in retrospect turns out to be the second time he's had that, he just didn't bring it up the first time. This person in my hands, I would explain to this athlete that if their goal is to return to the game of football, surgery is their path to returning to the game of football.
And Dave, one more time, how much does the position matter? So Wellington Sue has taught me that there are skilled positions like safeties, receivers who do head turning, whose neck and head is much more exposed than, let's say, line people. I'm not even talking about punters and all that, but how much does that position and the chance to have some armor around your neck influence your decision-making?
I think of this more through the lens of high impact versus low impact sports and high frequency versus low frequency of those impacts, as opposed to the position. I don't think that there is a position on the football field in major college football or in the National Football League that does not involve risk and exposure. So I would not make a distinction amongst any position inside of the NFL or college football. But what's fascinating, and the premise of your question leads directly into where I was going to take this discussion, because Now we have this interesting scenario in college football where these players have relationships with agents, and that the NIL has opened the door to college football now being a lucrative sport for many of its participants. And so the question is asked, can I have an arthroplasty instead of a fusion? Who would consider performing arthroplasty in a high frequency, high impact sport like football?
Let me ask the audience here and poll them. Dave, I don't know whether you can see the audience. So who would want to do an arthroplasty, C3-4? A show of hands, raise your hands. Anybody? One person. On an NFL player, Richard.
Yeah, I certainly don't have experience with taking care of the high-level athletes. However, I know there's been a precedence recently in NHL players
3
to have arthroplasty over fusion. And I know it's still very, very debatable, but I think doing both operations, I might consider this, again, having no experience taking care of those athletes.
Liz, let me put you on the spot. LA, just a little competitive market, competing institutions. Disc arthroplasty, yes, no, why no?
Well, I am not unbiased in this, as I think football and contact sports should really be illegal. I think there are a lot of brain injuries there. But putting that aside for the moment, I really would not do an arthroplasty in a young person like this, a 21 years old athlete. They're at high risk, again, for some instability here. Clearly something is going on where the cord's being dinged, and it's really just not worth it. ACDF is a great operation. It stood the test of time. And for this specific type of impact, I would want the most rigid construct possible.
Dr. Lord, I agree with everything you just said, except the issue about these sports should be illegal, and that's a topic for another that's a topic in a conversation for another day. But I think on balance, the benefits of these sports outweigh the risks.
I'm going to let Dave talk. We might be here until Sunday. The issue is the sport you're talking about. And football, to me, is a completely different mechanism of injury than hockey. Hockey guys rotate their head. It's much more important to them to have a swivel on their head. And the axial loads, you don't get a lot of axial compression in hockey. So I would say hockey, I would agree with it. Horseback riding, some of the other things. NFL, I probably would say I would not recommend an arthroplasty. That'd be my comment.
Let's show of hands. Fusion. Who would want to fuse a patient? A vast majority. Who would disable the patient? Nobody. Okay. Tell them you're done with high impact sports. Nobody. Okay. Did we kind of move forward now? But there's a strong preponderance for ACDF here over anything else.
Yeah, so there's no one in the National Football League with arthroplasty. There are many, many, many examples. And again, the most frequent level is C3-4 of ACDF. There's a lot of things to consider here about choice: allograft, autograft, synthetic, fixed angled screws, biologic, et cetera. Someone brought up the fact that there are 3 NHL players. There is also Jesse Winkler in the MLB, and as well as an Aussie Rules football player. There is one case report of a 2-level arthroplasty in a college football player, but that case report mentions nothing about return to play or whether the athlete was, retired from the sport. It's so fascinating. It's a case report that says we did a 2-level arthroplasty and the patient had a resolution of his symptoms, but makes no mention of anything else. So it's like, okay, thank you very much for telling us you did a 2-level arthroplasty. There are lots and lots of people who have had arthroplasties across numerous sports. And this is, only getting more and more common. The NHL players had equal performance statistically after their arthroplasties compared to before. Scott Zuckerman is and I've had so many conversations about this. I've actually learned quite a bit from him about this topic. And he and I and Alan Sills, Nick Theodore are in the process of doing a Delphi method approach to this question with a global collection of spine surgeons with experience in the elite athletes. So stay tuned for that. We're still several months from doing that. Arthroplasty is not without risks, and our former resident Christian Ricks recently published this case report of someone he took care of where he did not do the arthroplasty, but after 9 years after arthroplasty, his patient fell and ended up with implant extrusion into the spinal cord. So, things like this make it say to me, I am not going to be the first person who does an arthroplasty in someone who's going to the National Football League. In all of these case reports and case series, nothing in the NFL. So he's now 5 months post-op. There's his post-op imaging, incorporation of the graft, arthrodesis, restoration of CSF around the spinal cord, resolution of the T2 signal change. Would you draft this person in the National Football League?
Yes. Let me ask the audience. Yes? Everybody says yes. Yes.
How good is he?
Nobody says no.
He's chosen to play one more year of college football and put his hat in the ring for next year. He has an extra year. He actually has 2 more years of eligibility left, but he was on a path towards potentially an early draft, but he's decided to play one more year. Yeah.
Dave, I got a question about your graft. So, and this is actually, we have some international people, and we need to include you in that for sure with Wellington Sioux. For some reason, these high impact players don't heal their allografts very well. And there's a rising group of people who think that they should have an iliac crest autograft gasp put in, or a titanium spacer with plate. Did you see this? Is there any rhyme or reason to this, or was this kind of idiosyncratic?
It's remarkable. And, I have another case that I could show. It's incredible that you would think that the person in his early 20s who is not only healthy but is super healthy, right? These are elite physical characteristics, and yet the arthrodesis rates are meaningfully lower than the general population, and I'm not entirely sure why. So I have colleagues who operate on this patient population who use synthetics purely because they don't want to deal with the hassle 9 months later of was there or was there not complete graft incorporation. There are numerous players in the NFL who have had incomplete graft incorporation, but have a stable instrumented fusion and are back to play. So that's another topic of controversy, is do you actually have to have fully bony arthrodesis if there's no loosening of the hardware and there's no motion on flexion extension? Do you actually need arthrodesis? And I would argue, no, you don't actually need complete arthrodesis to return to play. For the moment, I have stuck with using allograft because I think it actually is the correct long-term choice, even though it creates medium and short-term headaches for the surgeon.
Thank you. Hey, how much longer do you have, Dave?
No, I was going to stop there. I mean, I could keep going and going and going, but I was going to stop there.
Now, we talked about laminoplasty before. Is that something that you'd allow in a suitably selected patient with a well-performed technique, that you'd allow them to go back to contact sport? Do you know of any laminoplasty patients in collision sports?
I don't know of any laminoplasty patients in collision sports, and I would be very concerned about that. I would not be concerned about that for basketball. There are these other things where, so basketball, you're exposed, right? You go up in the air, someone undercuts your legs, you can come down and, you can have a very serious impact, but the likelihood of that impact is low and the frequency of that impact would be very low. So as we're going through this Delphi process, we're also trying to group things into those terms: low frequency, low impact versus, high frequency, high impact, et cetera. There's a 2x2 table. Anyway, in the high frequency, high impact sports, laminoplasty, we go through this process every year through the NFL Combine and through the draft process. And, our front offices, all the front offices rely on the medical staffs to give them an indication of that player's risk to fulfill a contract, right? You don't want to sign someone, devote a lot of money to somebody in a salary capped sport, and then have your salary cap be eaten up by someone who's not on the field. And so they rely on the medical staffs pretty extensively for this process. And I would advise my franchise not to draft or sign a player with laminoplasty.
Outstanding perspectives. Thank you so much for your time and expertise. And maybe we can have a Philadelphia versus Pittsburgh repeat warfare this December for our spine trauma course.
Oh yeah, let's do it. Let's do it. I'm in.
Thank
Thank
you.
you guys.